Hello, my name is John Kirkestner. I am from University of Illinois, and I would like to talk to you about the economics of childhood obesity. I do not have any disclosures to report. To make sure we all define childhood obesity the same way, let's make some clarifications. At the 85th percentile BMI by age and gender, a child is overweight. At the 95th percentile, they are considered obese. At 120% of the 95th percentile, it used to be called severely obese. Many are changing the terminology now, and we call this class 2 obesity. At 140% or higher of the 95th percentile, it is called class 3 obesity. The 95th percentile was determined by collecting data from our youth from across the country from the late 1960s to the early 1990s. You can see the charts in the upper right here. I took them from the CDC website, showing their publication from the year 2000. This shows male in blue and female in pink. They are pretty similar, but there are subtle differences. Notably, female BMIs are slightly higher, as you can see in my graph in the bottom right. This means when we discuss present-day obesity prevalence, it is comparing today's BMIs to those of the children from a generation or two prior. The WHO says 160 million school-aged children are obese. CDC says almost 15 million American children are obese. WorldObesity.org says over 20% of American children are obese. That is 4 times higher than 50 years ago. The US is in the top 11% of countries for childhood obesity rates, and the US and the other highest obesity nations are not poor. The lack of resources is not the issue. This is also not just a US problem. Over 75% of countries across the globe have higher childhood obesity rates than they did 50 years ago. Some people may say not in my neighborhood, but the obesity rates are increasing across all strata of income. Wealthy, poor, wherever you may be from. Some may say it looks good on their kid, or that their child is an athlete and that's why they're heavy. They still will be at higher risk of developing the associated diseases and face additional struggles to keep that weight off in adulthood. The health risks associated with obesity comprise a long list: cardiovascular disease, diabetes, cancer of many different types, neurological disorders, chronic respiratory diseases like asthma, digestive disorders. There's also less obvious ones: psychosocial consequences, accessibility issues. Then there's discrimination, bullying, sleep apnea, mobility issues, associated with also back pain, joint pain, fatigue, even headaches. 86% of adolescents that are obese at age 17 will be obese at age 50. And the research that determined that percentage excluded all participants at the entry stage that they couldn't interview at the near age 50 stage. Any that died before that due to health complications, potentially related to obesity, would have maybe made that statistic higher. Overweight persons have extra hurdles to overcome when trying to live a healthier lifestyle. Habits have been formed. Exercise is more difficult. Even if their obesity is due to a genetic disease, less influenced by their behaviors, they still suffer the same associated health risks and hurdles to make positive change. Let's talk about some of the direct costs of obesity. Health care for obese children is higher. Class 1 obesity children have $150 more in annual medical costs on average compared to normal weight children, while severely obese children have an additional $400 in healthcare costs annually. In 2025, that will mean about an extra $3 billion spent providing additional healthcare to obese children. These costs aren't just in dollars. Obese adolescents miss more school than non-overweight adolescents. The children are getting sick more often, suffering additional psychological distress, and missing more education days. This will lead to further economic costs as the trends continue. Inequity with obesity affects blacks more than any other group. Black male youth are over twice as likely to be obese as white male youth. Black female youth are almost twice as likely to be obese as white female youth. Obese persons have 6 fewer quality years of life compared to normal weight persons. Research in the late 80s and early 90s found that income and obesity were inversely related. Higher income, lower obesity. Lower income, higher obesity. When performed again with data from 2005 to 2008, all the income levels had gone up, but the portion of the population at the highest income has significantly lower obesity rates than all other income levels. They have sufficient resources that the cost to always purchase healthy foods is of less concern. They live in non-food desert areas and have ample means for transportation and access. Minorities, people with less income, and people without access are all more likely to be obese. Obese people are over twice as likely to have hypertension and/or type 2 diabetes. Also, a significantly higher risk of coronary heart disease. Once a person has obesity and develops these associated diseases, it becomes that much harder to get out of the cycle. Next, let's talk about the economic causes of childhood obesity. The first problem is agriculture subsidies. These are allocated mostly to food assistance programs and then crops used to make unhealthy food additives. Insurance for those farmers, and CRP to not plant crops, even though sustainable crop rotations to replenish the soil are known. This is a big missed opportunity to allocate that money to subsidize healthy foods instead of being part of the system making unhealthy foods cheaper, failing to create a positive externality by making those healthier choices more affordable to grow and more reasonable to get to the market. Instead, this allocation to unhealthy food options has the federal government creating a negative externality by empowering a system that creates worse health outcomes for the public. We also have advertising dollars creating marketing campaigns to push the food that is most profitable, not most healthy. This asymmetric information floods the public with false information about the nutrient content of foods and stimulating ad campaigns designed to trigger subliminal ideas, encouraging consumers to make less healthy choices. People living below or barely above the poverty level are less likely to have access to fresh produce near where they live, leaving them in a food desert where their only choices are unhealthy eating options. This inequity is not a sign of a broken system, but the way the corporations in power and the politicians they fund choose to reinforce the rules of the system to ensure people suffer from these inequalities. Our public education often does not teach students how to acquire fresh produce within their means, nor how to prepare the food to cook for themselves. Education should be a public good, yet our math and reading levels suffer while the high school graduation rate increases. We are providing our youth with fewer tools to become healthy, productive adults, meanwhile pushing them up and out of the education system even though they have not received the basic education that they were promised. Corporations are encouraging the proliferation of misinformation across social media, empowering users with AI tools to spread fictional information presented as facts. This asymmetric information market failure affects public health heavily about obesity and what healthy nutrition is, but also on vaccines and other items that will reduce the public's overall health. We also see inequality significantly represented in urban areas without safe outdoor spaces for youth to be active while not in fear for their safety. Now that we discussed some of the causes, let's go over the economic effects of childhood obesity. Obese children have an increased risk of many diseases, as we discussed earlier. They have higher healthcare costs at an average of $400 per year per child and an average of $10,000 higher average costs across their lifetime compared to normal weight persons. They'll miss 37% more school days, 86% risk of still being obese at age 50, reduced physical mobility, capability, accessibility. Once employed, they are more likely to miss days of work, higher risk of injury, and the habits and lifestyle that often lead persons to this disease of obesity are taught and handed down to the next generation. A child with one obese parent is 50% likely to also be obese, but if both of their parents are obese, that increases to 80%. To clarify, that is nature and nurture. I'm not suggesting otherwise. 16% of Americans, 55 million people, are above the poverty line, but below double it. This leaves them in a situation where they make too much for government help, but too little to have autonomy in their life, to take control and improve their outcomes. Not for them, not for their children. This creates a cycle where those in power keep these people poor and with less access to the resources to help them break the cycle and find healthy outcomes and security. Okay, so many bad things. We're going to change it up and talk about solutions now. At the federal level, which will require state level support, the Farm Bill. Get the agriculture subsidies for crops used to make unhealthy food to stop. We can also get additional funding for health and education programs by taxing those unhealthy food and drinks, loaded with sugar or its replacements, fatty content, empty calories. We can redirect those additional resources to provide subsidies for healthy foods and making sure they can get to market in a reasonable amount of time at a price the public can afford. We can also be part of the solution at the local level. Shop local, visit farmers markets and buy their produce. From spring into fall, I am able to buy most of the produce we use from there for far less than a meal deal from a fast food chain. Boycott the stores and corporations that flood media with unhealthy marketing campaigns targeting children. The only thing that will change their approach is our dollars, or in this case, the lack of our dollars. Participate in organizations in your community. Encourage your friends and family to actively engage. It is a great opportunity to learn what people in your town are doing to help and where you might best contribute. Continue learning, sharing, teaching ways to be healthy and to find and prepare the food and lifestyle that will get you on track or keep you on track. Advocate to your schools. Let them know that nutrition and healthy eating for our children is a priority. Finally, contact local businesses you frequent and convey your priorities and how they can play a part in these solutions, how they can devote their resources and direct their marketing campaigns to be part of that solution. Let's sum things up. Lowering obesity prevalence increases the number of quality adjusted life years in our lives and our friends and families' lives. Lowering obesity prevalence reduces how much we spend on healthcare, both in our households and by our country and state. Lowering obesity prevalence increases our potential, making it easier for us to learn, do our jobs, and engage with the people important to us. Lowering obesity prevalence reduces the chasm that exists between people of different socioeconomic status. Lowering obesity prevalence is going to be an uphill battle. The system has settled in on being this way, and we will need to work to change it. Lowering obesity prevalence takes a village. Whole communities will need to work together to change the trajectory of this public health epidemic. Here are my references. I encourage you to ask questions, let me know what you think and comment, and help be a part of the solution.